Hello again. This is your Health and Science Focus. I'm Yuveka Rangappa. Thanks so much for joining us. We're still talking about aging, and we're talking about the mental and cognitive effects of getting older. Let's talk now about Parkinson's disease with one of the country's leading Parkinson's specialists, Davies Anders from Wits University's Donald Gordon Medical Center. Doc, a very good morning, and thanks so much for your time. So let's look at, I'm not sure if you heard the conversation we just had about Alzheimer's disease as well, but is there a link? Is it interlinked with Parkinson's at all? Is there anything that links the two?
Good morning, and thank you for having me, Becca. The answer is definitely. I think a good way to conceptualize it is that we are all born with a certain number of brain cells, and those brain cells are the same brain cells we have when we are 5 years old or whether we turn 100 years old. And there are very complex mechanisms that over the last few decades we've learned to keep those cells alive. And depending on our genetic predisposing factors and depending on the environment that we're in, some of those factors start to break down. And depending on which part of the brain is affected, that will determine which of these neurodegenerative conditions that you get. If it is a memory problem principally, that's Alzheimer's disease. And with Parkinson's disease, this condition is a whole body disease, but we all see it as a movement disorder with, as your first speaker spoke about, tremor, slowness. But Parkinson's disease is a whole body disease, and certainly does affect the brain, but also affects other organs in the body. So
how is there an average age when it comes to Parkinson's? And I'm thinking now of many, many years ago when we heard of someone like Michael J. Fox, who was quite young, and I'm not sure if that's exactly what he has. I think it is Parkinson's, and he was very young. He wasn't even, I think, 40 when he was diagnosed with Parkinson's. Is it necessarily an old age illness or disease?
Well, firstly, Michael J. Fox has done an incredible amount for our community. It is unusual to see young onset. If we look at the numbers, if we take the age of 60, about 1 to 3% of patients at 60 have Parkinson's disease, and that goes up to about 5 to 8% at the age of 80. But we are seeing younger and younger cases. But Parkinson's disease, out of all the neurodegenerative conditions, is increasing in its number. In 1990, there were about 2.5 million cases, and today there are about 7 million cases worldwide, and that's probably an underestimation.
Why is that, though? Is there a reason as to why we're seeing such an increase?
Well, we think that it is because the world's population is getting older, but we're also seeing that there are environmental factors. There might be toxins. We also think that it might be diet-related. We don't know what those final factors are that are causing Parkinson's disease, but we think it's a combination of the environment, genetic predisposing factors, and the fact that the world's population is getting older.
Now, you also specialize in epilepsy. Now, we know that this can happen in kids as well, but as we get older, are we more susceptible to epileptic attacks or fits? And is this linked as well to things like Parkinson's and Alzheimer's?
So the answer is yes. There are two sort of spikes in the incidence of epilepsy. There is a young onset, and those are often genetic-related conditions. And then there's a second spike as a person gets older, and those can often be focal, either due to an injury, due to a stroke. And in some cases, seizures can precede the onset of dementia.
Okay, well, it does sound like a very scary place to be, Doc. And at this point, I suppose many people will want to know, okay, so tell me how I would know. What are the signs and symptoms that Parkinson's might be setting in? And also at the same time, what treatments are available out there?
Well, this is where there is some good news. When we look at Parkinson's disease, there are some incredibly good treatments. Since the 1960s, in fact, even a little bit before, we discovered that the chemical dopamine can dramatically improve the quality of life of patients. And if you get the right treatment at the right time, patients can remain well and have a good quality of life for many, many years. There is also good surgery, and in the last decade, our surgical techniques to improve the quality of life in Parkinson's patients have dramatically improved. And recently, in fact, this week at the World Movement Disorder Congress, when we look at the future for treatments in Parkinson's disease and other movement disorders, it really is looking exciting. With regards to the signs and symptoms, there can be the movement symptoms of slowing down, tremor, but it can be sometimes more subtle. It's also, as I said, a whole body disease. Sometimes it can be late onset anxiety, depression. It's often associated with constipation. And these symptoms can predate the or part of the prodrome of the movement disorder. So it is important to see a doctor, and preferably a neurologist with an interest in movement disorders.
All right, Dr. Debbie Anders, thank you so much for that. At least some good news. We are seeing some strides being made there in at least treating one of these aging illnesses or diseases. So we're still talking about this, and let's chat now to Debbie Beech. She's a social worker at Ron Smith Care Centre in Gauteng. Debbie, thanks so much for your time, and yours must be quite a difficult job and a very sensitive one as well. So you firstly give us an idea of who is it you actually take care of.
So we are a care centre with over 130 residents in our frail care, and predominantly we specialise in people with dementia.
So what is it, at what stage do your, can't call them patients exactly.
Residents.
Your residents, at what stage do they come to you? Does the family say, we can't do this anymore, it's time to hand it over to professionals?
Usually, and unfortunately, the families are in crisis when they come to us. There's been a fall, a fracture, an incident, and they've really come to a point where they realise that their loved one is not able to look after themselves anymore, and they cannot manage themselves. Often the family members themselves are burnt out, carer fatigue, because they bear the brunt of it, and then they bring their loved ones to facilities such as ours.
What's involved in caring for a resident who has something like Alzheimer's, dementia? Do you deal with Parkinson's as well?
Yes.
Some of them would be having that as well?
You know, we work very much from an individual point of view. So it's part of what we call the Eden Alternative, which we are registered in. And it's an ethos, and it's really about deinstitutionalising the facility as much as possible and customising it to the individual's needs. So it's very important for us that we know the likes and dislikes of the residents, and we know their history, because often it explains a lot of the behaviour. Because with dementia and with Parkinson's, often speech is affected. So the resident is not able to say to us what they like and don't like. Small things, maybe they always had their bath in the evening. That makes the world of difference. If you've got somebody that you are insisting baths at 6 o'clock in the morning and they never have done, they're going to be your difficult resident, whereas actually you're taking them out of their normal usual routine. And this is what we focus on very much.
Now, I don't want to put even more of a downer on this, but is it necessarily that when a resident comes to you with something like Alzheimer's, dementia, that is the sign that the end is near for them?
Yes and no. Particularly with dementia, the person is often still quite mobile and up and about. The stereotypical concept with a frail care is that the person is bedridden. And yes, we do have residents that are bedridden, but a lot of our residents are physically quite healthy. But mentally, the dementia has taken its toll. And because of that, and because they no longer have executive function and are able to decide and reason, they are in a place where the structure and routine and to ensure that the daily activities are met and done properly. So we have residents that stay with us for a number of years and do very, very well within that structure and routine.
So, just having listened to cases and friends and family who've had to deal with this as well, you get to the stage where somebody is almost like a baby again, where they can't even tie their own shoelaces, they can't even button their own clothes. And eventually, is it that they forget to eat? We had one of our doctors talking about losing weight. It could be a sign of Alzheimer's. Just take us through, because you're as good as a doctor, I'm sure, with all the experience you have, of what the breakdown you've seen in your residents, and as they get to the end. Is it because organs start shutting down, that the messages are not going from the brain to the rest of the body?
So, dementia is a terminal illness, and at the end, yes, the brain does start shutting down, and swallowing starts to become a problem, the swallow reflex. So obviously, if that is a problem, eating becomes a problem, and then we will get a speech therapist in and maybe look at thickened fluids. And, you know, the important thing is palliative care. It's about helping the person die with dignity.
Yeah.
And a good life deserves a good death. And unfortunately, in our society, there's a lot of stigma around talking about end of life and end of life care.
Yeah.
And that is where we come in, and we have those difficult conversations with the families to prepare the families and to make sure that their loved one is comfortable and dies with dignity at the end.
Yeah, and I think sort of, you know, just a bit of reassurance for the families out there as well. We've heard the horror stories, you know, often there are not everyone takes the care that you guys might at your facility. People fear that their loved ones are being badly treated, forgotten, just left to die in their beds as well. Just some reassurance that, you know, not everyone is like that, and that the best possible care is given to them till they get to that end.
You know, you place your loved one in the care of professionals, people who have a passion for this work, and people who do this work. We know what we're doing. So you're pushing your loved one in good hands. There is often a lot of guilt associated with that. The family often feels they've abandoned their loved ones, that they're giving up on them. But we actually find that the relationship with the loved ones and the residents actually improves. Because the stress levels are reduced. The family member is not worried about, have you eaten, have you bathed, have you done this, have you done that. They can actually come and visit and spend time together. And particularly at the end, it really becomes quality time and treasuring those moments that you can have, knowing that your loved one is being taken care of in the best possible way.
And I think very quickly for us, why it is at that stage that it is better, and not to feel guilty. I think guilt plays a big part in this as well, Debbie, for people who have to, at that point, put their father or mother or grandfather or grandmother in a facility.
You know, the reality is that often family members feel guilty for wanting to have a life. And when you are caring for somebody with dementia, somebody who's ailing, that becomes your life. Your whole life revolves around that. And then you burn out. And there's nothing to feel guilty about for having a balance in your life.
So it's what's best for everyone.
Absolutely.
Debbie Beech, thank you so much. Such a vital but tough job you have, and thanks for the care you take of our elderly. Still to come, getting older is a bit difficult to deal with for some people. It takes its psychological toll on you, comes with a lot of sadness and acceptance as well. We'll chat to a psychologist about the psychology of aging in just a bit.